Thanks, everybody. Pleasure to be here at another incredible OIS event. Craig, thank you for once again bringing us all together in person and allowing us to actually enjoy our non-Zoom communication with each other. It's an exciting topic to be able to speak about, and I sort of feel like it's taken about 16 years for the fallout of memantine to settle down before we've been able to come back and discuss neuroprotection as not only a viable development opportunity, but one that's certainly deserving of increased investment. I'm pleased to be joined by three incredible people on this panel who I think bring completely diverse perspectives to both the concept of neuroprotection and to how we should go about pursuing it. So the first is Sharon Backlash. Thank you, Sharon, who's the founder and CEO of SB Strategic Development Consultants. After a storied career inside of Big Pharma. Dr. Hassan Sadri, who I haven't seen it live probably now, and I don't even know how long, who's a CEO and founder of Visionary Eye Institute and a founding board member of Visionary Venture Fund. And Dr. Gus DeMorais, who I think I dragged here by his hair today, who's the Chief Medical Officer of Aura and also an Associate Professor of Ophthalmology at Columbia New York Hospital. So thank you all for being here. I think that we're going to start with Sharon. I think probably it's an important question to ask and one that the audience needs to hear, which is for you to help us discuss what neuroprotection actually means. You know, it's a confusing topic for me. Not only we just see presentation from three companies that are looking at neuroprotection from completely different perspectives, but also, I sort of felt like everything we do is kind of neuroprotective, right? I mean, lowering intraocular pressure for glaucoma is a surrogate neuroprotective therapy. But ultimately, what is it? I mean, I know you know because your PhD was on neuroprotection, right? So you may maybe tell us a little bit about what your idea of neuroprotection is.
So just a short a short piece of information that you guys need to know. Dr. Michael Yang, who was just on the podium, was my PI during my postdoc years at Harvard. And I am elated that 20 years later, now you know my age as well, this is actually coming to fruition. And essentially, Rob, I think what you're asking is a spot-on question, because in essence, in the CNS in general and in ophthalmology in particular, we all know that primary degeneration processes happen as a result of a primary trigger. But because of the nature of the immune privilege of the CNS and in the eye, the secondary degeneration processes are much bigger. So it's like a stone that you throw into a lake. The stone itself has a ripple effect that is beyond proportion in the CNS. And what we're talking about is in essence, when we talk neuroprotection, is enabling those damaged neurons to continue to survive and limit the damage to as minimum as we can. That's what neuroprotection is. And I know that for you coming from glaucoma, this a lot of the times is associated with glaucoma, but it's not the only thing. We need to put, we need to call it for what it is. Neuroprotection is relevant for retinitis pigmentosa, like we saw now. It's relevant for glaucoma, obviously, but for all kinds of retinal damaging processes, acute and chronic. We, I think, have been neglecting to look at neuroprotection as a target, as a result of common history that some of us share that have been within the field for a long time. But it's time that we raise it back into consciousness and we look at this as a valid target for continuing technologies and innovations in the field.
Thanks. We're going to get back to you a little bit later, but I want to ask Hassan a question because everybody up here, interestingly, is a medical doctor. So we've all actually practiced clinically as ophthalmologists, and I think Hassan and I, unfortunately, still do quite a bit of that. But Hassan, how important is this as a concept? I mean, when you're talking about treating patients, right? We're trying to figure out how to make them not go blind. Neuroprotection is not something that we can offer our patients as a therapeutic option right now. We can say, for example, glaucoma is the easiest one to talk about. We can lower your pressure. That'll help prevent visual loss down the road. But how important it is for have some sort of pressure-independent therapy to treat patients with neurologic disease of the eye?
Well, I mean, first of all, you and I fell in love somehow with the dark side. I don't know how with glaucoma, and we still practice every day. But there's some of the nearest and most probably, in my opinion, closest patients that we have. We've really formed bonds with these patients over the years. It's frustrating. It's sad. A lot of them really are frustrated because, you and I manage patients, and I'm sure the doctors here do. You give them the best medical therapy, their pressures are doing great, but they still lose optic nerve functionality. So I think I'm super excited for what you were saying, and the comments you made are 100% on board, because we really don't have anything, because the patients could be a fast progressor, right? We've seen Caprioli's work from UCLA that shows you can have great inocular pressure, but you have actually worsening of glaucoma. And from the AEGIS trials, we know that even though you get lower pressure, there's a large subset that still progress. So neuroprotection must be and should be in our armament in the bag coming out. And as you know, because you're practicing still, everything's commoditized. I mean, if we're looking at venture, if we put the venture hat on, and I know you do that really well as well, is what is exciting about the next lowering drop? I mean, there's medications out there that we're working on, that's exciting, but really at the end of the day, medications do work well that we have in the marketplace, but really we're sort of hitting a wall. And I think it's exciting to really put input and focus on neuroprotection, specific in glaucoma.
Right. I mean, and I agree. I think IOP lowering, as we all agree, is just one thing that we can do. It's the only thing right now that we can do clinically to try and protect the optic nerve. But I think it's sort of a constant reminder that we really don't know what's going on, right, with glaucoma disease and what the real nature of the damage is. So obviously I agree. I mean, people ask that all the time. Well, patients say, well, how do you stop me from going blind? And we can't. We can just slow it down. So we probably hear the same questions. Gus, one of the reasons that I wanted you to be here is because I think one of the things that was apparent after Allergan's attempt at looking at memantine for neuroprotection was that there were some significant failures in patient selection and trial design, which you'll hopefully discuss briefly here. And you recently published an article, which I'd like you to discuss, which I think may forever change the ability for companies to conduct neuroprotection trials going forward. And it's something that could be transformative in the space and hopefully will allow for certain entities, at least looking at neuroprotection as a glaucoma asset, to have a faster, less painful, and certainly less expensive route to the FDA. So can you touch on all that?
Yes. With regard to the memantine trial, so for those not familiar, it was a very expensive, two identical randomized trials testing 2 doses of memantine and placebo for 4 years with a total of 2,200 patients, which failed to show its primary endpoint or any difference using the FDA-approved endpoint for neuroprotection, which is based on visual fields. And I would classify the failures. Let's forget that there's a possibility that the drug may not work, but let's focus on inclusion-exclusion criteria and endpoint. That's usually where the problem is. So they included a huge proportion of patients with very severe visual fields at baseline, which we know have a very significant variability, and your ability to detect progression accurately is very limited in that group. They also allowed patients who were very stable to enter the study. Patients who had trabeculectomies or filtering procedures within 3 months were allowed, and we know these patients are not going to progress. And I mean, they tend not to progress or progress very slowly, so your ability to detect difference between groups from endpoints will be limited. And also the treatment, even IOP lowering, was left at the discretion of the physician. So if they thought that the patient was progressing, they could enhance IOP lowering therapy. So the effects of the neuroprotective drug may have been masked here. And finally, in terms of the endpoint, they used the view of this an FDA-approved endpoint, 5 points on the GPA, GCP back then. But they did visual fields very sparse, like one test every 6 months in a population with high variability of visual fields. So it may have been a lot of the patients misclassified as stable or progressing just because the endpoint was not properly selected. So you can see here a pattern of selection of the sample that's more likely, that's in this case less likely to progress, and use an endpoint that's not very sensitive in that population. And what we did in that paper is, in conjunction with other papers our group have worked, is to minimize the variability of testing by using the mean deviation, which is a summary, has less variability over time, and look at rate of change, which is something that in GA trials is now used as an endpoint, rate of change. And by increasing the frequency of testing, the beginning at the end of the trial, an approach that was described in the UK GTS trial, seemed to help improve the ability to detect progression. Now, instead of 4 years, we're now showing that in 12 to 18 months, you can see that. So, but the question is, does the FDA accept that? And that's what we try to tackle. And so based on some discussions we had with the agency, if you're able to demonstrate that that endpoint is strongly correlated or predictive of one of their accepted endpoints, then that could be done. So that's what we tested. Of course, it's not just MD slope, it also depends on the population you're going to enroll, the variability in that sample, but it is perfectly possible to design, choose that as an endpoint, that it meets the FDA's requirements for an endpoint, and still have a trial that lasts perhaps 12 to 18 months. So that's the summary. So trying to address the issues with the memantine, and now proposing something that could be more helpful for drug development.
Okay, so you're talking about a substantial savings in terms of the amount of time that it can take to reach a clinically meaningful endpoint. What about, does that change your ability to affect the patient selection process? Can you select better patients for these trials than had been selected before?
So the problem with a neuroprotection trial nowadays is that you have to have a treated population. Your placebo group is already on IOP lowering, right? So if you could do like in the UKGTS or EMGT, that you have a group that was not treated, you have more chance of finding effect. Now everyone's going to be controlled and progressing very slowly, likely. So what the strategy now is invest your resources on the selection of a population more likely to progress during the trial. So that's one of the things we propose in this and other groups have done, by either using historical data that you show that the patients have been progressing, because we know there's a linear correlation between before and after, but also if that's not available, based on some other parameters such as clinical variables like risk factors, that will allow you to do that. And also if you have a group of patients that's more trained with perimetry, have less variability in doing perimetry, they're also more likely to reduce your noise and improve your power calculation.
Yeah, I mean, I think obviously it makes incredible sense to be able to do that, and I think that alone and acceptance by the FDA of this prediction of progression based on this analysis will make it a lot more appealing. I mean, at least I'll put on my venture hat for a minute to be able to evaluate the potential costs associated with conducting a neuroprotection trial. This changes things dramatically. So let me go back to you, Sharon. You worked inside of Big Pharma for many years. What was the attitude of the companies that you worked for regarding their evaluation of neuroprotection? Was it even on their radar? Were they flat out no's? Did you look at things? And obviously you have expertise in that, so I'm sure they showed you opportunities. What happened?
So, like you said, this is a multifaceted problem. One of the aspects that was raised right now here was the FDA's endpoints, which are restrictive. They dictate long periods for clinical trials, large sample sizes of thousands of patients, and at the end of the day, this is a huge cost that you're taking at risk. The other part of the problem when it comes to neuroprotection is the inflation in the word itself. The word neuroprotection, I think in the psyche of our community, was overused over time for things that were or were not neuroprotective, and the problem within Big Pharma was, how do I evaluate what is neuroprotective or not? That's number one. Number two is, how do I get to the bottom of the mechanism of action exactly? Because in reality, it's very hard to define the difference between secondary degeneration processes and primary degeneration processes. What we're facing right now, and this is why this discussion is very meaningful, in my opinion, in this forum specifically, is because we have a chance right now with the rise in gene therapy, in cell therapy, in neuroprotective agents, in glaucoma, in retina. With that rise in new innovation, we potentially have the possibility of taking peer-reviewed articles such as Gus's and bringing it into FDA and say, look, we need to go beyond IOP. We need to form endpoints that, one, enable us to reduce the sample sizes, reduce the follow-up time, reduce the cost of those studies, and enable VCs and strategics to actually see the rationale behind investing in it. And with that said, this has to do a lot with AI. I want to also touch base on what George McGrath talked about earlier today from Lexitas, which is taking parameters from OCT that can also be very, very beneficial in deciphering what is the patient population you want to choose from the get-go, prior to joining the clinical trials, such as doing RNFL imaging or doing the inner plexiform layer around the macula, where you also take internal controls. So in essence, you can do the control within the same patient, just using different regions. This reduces cost, enables us to choose patients better, and we need to push for those endpoints to be meaningful according to the FDA so that we can enable the innovation to go beyond IOP.
Yeah, there you go. There's some,
Oh, thank you.
Don't be shy. You can clap all you want. I saw that. Hassan, so one of the things that came to my mind when I saw the Gus's article was that there are hundreds of companies that Visionary has probably spoken to over the course of their existence, as have most of the active investors here. Do you think that there's an opportunity now for some of these companies to either consider either a pivot or a change in protocol or an additional potential indication for neuroprotection as part of their development process, understanding that it isn't going to take hundreds of millions of dollars in 4 or 5 years of time to achieve? Do you think that this is something that's going to permeate into your diligence process so that people out here who are building companies can say, hey, wait a second, based on our mechanism of action, there's a chance that we're actually neuroprotective here, and maybe we should look at a neuroprotection opportunity here, go out and raise capital for that with these new criteria or new guidelines in place? What are your thoughts from the Visionary hat?
If you were talking about the venture, and the panelists earlier were saying is, if you talk about this next 12 months, this is not something that's going to happen in the next 12 months. However, if you ask me if in the landscape of 1 and 5 year plan, you can kind of see there's a lot of sponsors here that are actually working on neuroprotection, whether it's AMD or glaucoma. So the marketplace, interesting, is already gravitating towards it naturally because there's a lot of crosstalk there. And so I think you're going to see a lot of more interest, provided the FDA is flexible on their changing the parameters, so you don't have to do these lengthy, expensive trials. I remember when David Pipe was the CEO of Allergan, we would talk about memantine and how much money they were spending. All the Lou McGann road was going towards.
Exactly.
So, but in seriousness, I do think there's an exciting space here. If you look at the marketplace already, I can count about 4 or 5, maybe 6 companies here that are sponsors that are actually looking at this space, right? So that would not be the case if this was not exciting, and there's with the limits of funding that we have. I do also think that the patient, it's an unmet need. Glaucoma. Patients are living older and are wiser. There's not a day that goes by patients don't ask me, Doc, what's next? What can you do something to not only neuroprotect, but I would even go as further to say neurorestore. So there's a lot of, I think, interest out there to neurorestore the optic nerve functionality and maybe the retina. And I think that's going to be the next frontier for us as clinicians and as venture.
Yep. So, and I couldn't agree more. And I want to go back to one comment that Sharon made about the Lexitas presentation this morning about OCT, and I agree with you that I think that part of the interesting feature of that presentation was the ability to potentially change the process for selection for patients for clinical trials. So Gus, as a representative of Oral, two unbelievable CROs who are helping all of our entities out here, do you think that Aura is going to use this information and try and guide companies towards different clinical trial design now? Do you think that there's a reasonable approach? And when you give guidance to these companies, how do you perceive that it's going to change based on the information that you actually created?
Yeah, I think one of the advantages of CRO focused on ophthalmology like Aura is that we interact with the FDA on a regular basis, and we hear from them what they want to see. So not just in glaucoma, but in retina and other indications. So we have a feeling, like a sense of what's the next step in terms of what you need to present. So the data I just shared, for example, I cannot go into details, but we have some ongoing discussions, and I think between the endpoint and having some experience on what it takes to find those patients, because again, you're going to save money, the duration of your trial, in the number of patients, but you invest your time selecting the most adequate sample to be enrolled. So that's going to be a huge component, and that's where having some experience in not just clinically, but also in knowing what the agency wants to see may help as all these companies now interested come to the FDA for their products.
Yeah, Sharon, just going back to the whole neuroprotection topic for just a minute or two. One of the amazing things is that, and Gus, maybe you can validate my comment here because I think I'm right, but you never know. I believe that memantine did reach its secondary endpoint, right, which was showing stability in structural changes at the level of the optic nerve using optic nerve analysis, right? At the time, I don't think it was OCT. They used HRT at that time, correct? Yeah, I think. So, Sharon, should we be looking at other things? I mean, do you think that there's something else we should be looking at besides visual fields at neuroprotection at this point? Is there any other, something that we can identify as being neuroprotective besides a functional one?
So at the end of the day, the difference depends on what you see in morphology and function. And the FDA likes to use morphology and function, and it has to be very direct. It cannot be a surrogate endpoint. The tendency is to define everything that's morphology as a surrogate endpoint to function, and that's the main problem. So that leaves us with, one, selecting a better patient population before you start the study. Two is maybe look specifically in the case of glaucoma, not just in primary open-angle glaucoma as a proof of concept, but maybe go into open-angle angle closure, to acute angle closure glaucoma, where potentially the differences or the damage that's caused has a start and an end point. And therefore, maybe it's easier to define. But again, if we are using the common means of detection that we have been using so far, these are going to be very minute because a lot of the time morphology does not translate itself into function, and that's the biggest problem in glaucoma.
Go ahead, Gus.
I would add that just very recently the FDA announced that they will be open to use OCT as primary endpoint for a glaucoma trial, which is a big step in terms of what you're saying. Like what we're talking about, enrichment of the population, I would much rather have an OCT trial than a visual field trial, given all the issues with the subjective test variability. So that's a path that's there that may be helping us getting this moving faster. And going back to memantine, so it was actually they used the FDT, and they showed that in the population with the no low pressure, higher pressure population, which again goes back to what I said earlier, the ones who were not treated too aggressive at the beginning, that's where they showed a significant effect. So a lot of money spent, they could have checked that a little bit earlier to make sure it was right.
So I'm going to re-quote my favorite quote of the day, which goes to James Murray from Excite, who stated that nature abhors a vacuum. And I think that the concept of neuroprotection has been sort of left in a vacuum for quite some time. And I'm excited that we had at least 3 companies here today that are focusing primarily on neuroprotection sort of qualities for their asset. And I hope that at next year's OIS, we see a bunch more who are going to show us some positive data as well. Thank you to those companies and to this amazing panel for your time today.
Thank you.